and I thank the organizers, especially Omar, Dr. Pradeep, and Dr. Jeejesh for having me to talk on why my fellows fail as the opening batsman for today. 6% of the fractures which orthopedicians treat comes from proximal humerus fractures, and many of which, when it gets displaced, we tend to operate. And the commonest implant which nowadays we use for proximal humerus fixation is Philo's plate. And if you look at the literature in the recent times, the fixation complication for Philo's plate is alarmingly high, and it goes up to 34%. So the causes of failure, if we look into, we can see it can be mechanical bar implant related, it can be surgical or technical errors, it can be biological factors like osteoporosis, it can be patient related factors like malnutrition, diabetes, things like that, and fracture pattern related like forepart or head splitting fractures. If you analyze all these complications, it narrows down to three main problems. These three are the modes of failure. One is the varus position of the proximal humerus. It can be early due to poor reduction at the time of surgery itself when the neck shaft angle is less than 125 degrees, and late collapse due to absent medial calcar support or poor bone quality in especially osteoporotic bone. And as we all know, about 19% of the cases develop avascular necrosis eventually, and it can, in some patients, if there is screw penetration or things like that, you can have symptoms. Otherwise, it can be asymptomatic, and if there are vascular compromise, it can lead to non-union. So what are the strategies currently we have to avoid this varus collapse and early failure or late failure? The proper reduction at the time of surgery and meticulously maintaining it. The use of cuff sutures to the plate is a very helpful tool in avoiding collapse. And secondly, the calcar screws are very important in maintaining the neck shaft angle. And current literature again has doubt on medial strut graft because of either fibular allograft or autograft because of the increased dissection in the medial side to place it, and the modified calcar ratio where you will be increasing the calcar screws. So where do we stand in 2026? Earlier, Hertel's criteria was being followed to do a hemiarthroplasty or a reverse even when there is a medial hinge major loss or less than 8 mm medial strut or a head splitting. But current studies has questioned the Hertel's criteria, and they say even with the Hertel's problem, we can get away with the fixation. And fibular strut, as I already told, it's in doubt. So this is a patient who is a 67-year-old female with a two-part fracture with a gross varus, and medial comminution is definitely there, but we can't see because the bone is so soft, and there is a gross varus and osteoporosis. How will you proceed? So we have two new things coming in these 2023 to 26. This is a paper from All India Institute, Telangana, by Srinivas Kasha et al. They have extensively studied on medializing the shaft for preventing a varus collapse lately. And there is another study from Park et al. From South Korea, which shows bending a plate to make the proximal humerus valgate is helping in reduction. So there is a bit of a history on this. These are the two methods which they follow. The history is nothing. In KOACON 2018, from our institution, I have presented a case series of 33 cases where medialization of the shaft and valgation of the proximal humerus by bending the plate could save a lot of cases. And our research was promising, and for the last 10 years, I was following the same. So the same case, here what the procedure done was medialization of the shaft by bending the plate. Bending the plate, the medialization shaft automatically occurs and the head will fall into valgus. Now you can see the calcar support is well maintained, screw length should be adequate. Adequate means unlike proximal femur, it should not be subchondral, it should be at least 10 to 15 mm away from the subchondral cartilage, because it definitely will collapse. And calcar screw should be in good place and good spreading of screws will be there. And this is a simple thing, the GT should be brought down, the head should be valgaced and shaft should be medialized. You will get a support and you place the plate. And the surgical side, you will be using ethibond, the superior, anterior and posterior sides, and you can see the surgeon bending the plate, and once you bend the plate and place it there with the sutures, you can impact the shaft so that the medial continuity is well maintained and the screws are adequately placed and the closure is subsequent. So in this case, it's a head alone is separated. In our Hertel's criteria, we will be trying for a hemi or something like that. But here also we can get away with fixation. And you can see it has healed nicely and the function is also good. Yet another fracture, again the same principle. See how beautifully the medial side is getting healed. And it can be also done in a shell-like head where you can bang in your proximal shaft into the impacted head and again we will get. It's another head splitting fracture, again same principles. You can see it is healing very well. No signs of avascular necrosis. This case I have done last week, 67 years, severe osteoporosis. You can medialize the shaft and valgase the head, you get a position like this. So, in a nutshell, philos can fail, but if you follow the principles of a plating, as in any other area, opposite cortex of a plate should be continuous. That's medial continuity is a must. For that, you need not dissect there. You just valgase the plate. You medialize the shaft, avoid early and late virus, thus use sutures to the cuff, to the plate, and valgasation and medialization is a new tool for maintaining it. Thank you for your kind listening.